Hey everybody, Karen Anderson here with Aortic Hope for yet another special live event during this Aortic Disease Awareness Month week, Heart Valve Disease Awareness Week. I don't know, like tomorrow's going to be another day. It's a very, very, very busy month. Before we get started, do me a favor, click subscribe. Now, someone did ask me about this earlier. When you click subscribe, you can actually change that to have it say all, and then it looks like the bell is moving. That means you're going to get notified. Like just click the all of the things. Every time we come up, you'll be notified. That's how that kind of works. It has a little picture of a bell. So click that and then you'll be told every time that we're going live on here. So today it's our first, isn't this our first time doing this? I think it's our first time.
With us, yes, you and I.
Yeah.
You and me.
Yep. This is Robyn Peacock, and she is with Heart Valve Voice US. So I'm going to let her tell all of you a little bit about herself, and then we're going to just jump into our conversation. Hi.
Great. Hi. Well, thank you so much. And thanks for having me. I love sharing my story. I think sharing stories saves lives. It's a favorite hashtag I keep using. So my name's Robyn Peacock, and I am 62. The reason why that's important is because I want you to know that I have valve disease, is not just an older person's disease. 60 is not old. I was diagnosed in my 40s. So kind of the background on that was I was born with a bicuspid aortic valve, which is a congenital heart defect. But I was adopted. I didn't know my birth parents. I didn't know my medical history. So fast forward to 2003, and I'm with my best friend who dies of a massive heart attack. And what I now look back and say on her story is if we had known about women and heart disease in 2003, she might still be alive today. So because of her death, I became very proactive about my heart health, thinking, here's my best friend, my doubles tennis partner, mother of two small boys, who just dies. Like, it was instant. And I thought that could happen to me. I mean, I don't know. So I went and had a coronary calcium scan. I referred myself. I had an internist at the time who told me that just because I was fat, he wasn't going to help me. And so I didn't really have someone navigating my health with me. So I thought, well, I get these ads in the mail that tell me that this calcium scan is going to tell me if my arteries are clear. And I just assumed Maureen died of clogged arteries, because that's all we really knew, is that men died of heart attacks, and it was clogged arteries because they were overweight, unhealthy. So I just took that reasoning into my own space, and the calcium score came back clean. I was a 0, but there was a footnote that said dilated aorta, and no one called from Harbor UCLA. I'm going to put it out there because I want them to improve their practice. And no one called to tell me that I had an aneurysm, and I didn't know what dilated aorta was, never heard of it. So I Googled it, figured it out, ended up at Cedars-Sinai with a great team of doctors, and that's where the bicuspid valve was discovered. So I'm sharing all of those details because I think it's super important for us to, take charge of our own health. And I didn't have symptoms. There was nothing wrong with me other than I had put on quite a bit of weight since Maureen passed. But it was her death that propelled me forward. And so advocating for myself, I discovered the aneurysm and the bicuspid valve. The great news is that I was on a watch and wait for 15 years, meaning my aneurysm wasn't big enough to operate. I had not heard at that point of what aortic stenosis is. So that's a whole nother piece to this puzzle we'll get into in a little bit. So you fast forward to 2022, and when I have my open heart surgery, and at that point, my aneurysm was still at about a 4.8, but it was the valve. This is where aortic stenosis came in, and I started learning about aortic stenosis. So aortic stenosis is when your valve gets heavily calcified, meaning all these little calcification deposits kind of take over your valve, and your heart is working so hard to push your oxygen-rich blood through the valve back into your body. So some of the symptoms I was having the year and a half up to my surgery: extreme fatigue, brain fog, shortness of breath. I couldn't finish a sentence without taking a big gasp of air. Things that were really not my normal. And, we all have our naps in the afternoon sometimes, but these were extensive naps. These were 3-4 hours long, and I would just wake up exhausted. I didn't understand at the time that my body was struggling because it was lacking oxygen flowing through the body because this valve was diseased. I share the symptoms because one of the things that happens, obviously, as a woman in her late 40s, early 50s is the whole menopause era. And a lot of the symptoms that I had I was being told that's just because you're in menopause. That's just because of this. You have anxiety, those types of things. And so one of the things I know, Karen, you're huge about, we all are out here in this patient world, talking to people and telling people to, keep going after those symptoms. Don't be dismissed, especially if you're a woman. So we can answer some of those questions in a little bit. But after open heart surgery, I woke up with an epiphany. It's like, I need to get out in this world and start talking about my story, because I have a story of delay in diagnosis, missed diagnosis, dismissed symptoms, those types of things. And we all have to own our story, own our truth. And it helps others. It helps others because it might trigger something in someone else, or listening to their neighbor that might trigger, and it might help that person go for treatment or go to find the answer to some of the symptoms that they're having. So I switched from the nonprofit world. I'd been in the world for 30 years on the women and children in crisis, foster children, homeless, those types of things, working in the nonprofit sector there. And I shifted over to this heart world. So I've been in it about 2 years now, and it's unbelievable. It is a magnificent space to be in, and it fuels my passion. So I just bringing education to people and bringing awareness, speaking to people every single day. This morning, I was at Cedars having my annual echo, and usually the echo waiting room is quite empty at 8 a.m. It was packed to the gills. So of course I started the conversation, and all of a sudden you're just hearing from all these different walks of life about their journey and why they're there and how they got there, and symptoms they had or symptoms they didn't have. And I didn't know this, or we didn't know this, or where do we go for support? Anywhere we can have the conversation, we have to have this conversation.
Yeah, absolutely.
We save lives.
Yep. Well, our new hashtag is that, we create awareness ASAP, because awareness saves aortas, period.
Oh,
So,
I like that. ASAP.
Oh, thank you. Thank you.
ASAP.
ASAP.
Hashtag. Okay.
ASAP. Yeah. So yeah, the stories are super important. And I know that you focus a lot on your story, whereas I now focus more on what I did with my life since my story. So let's move now into what you're doing in the heart world. So I've been trying to explain to the community, and I brought my board and other volunteers into the Global Heart Hub world, allowing them that opportunity for training and for webinars and to participate in some of their summits. But let's discuss Heart Valve Voice US.
So Heart Valve Voice US, we've been around, I believe it's about 10 years. And I joined the organization about 1.5 years ago, and I'm Director of Patient Engagement, which allows me such latitude to go out into the world and kind of just listen, and then take that information back to headquarters and say, these are the issues at the grassroots level. How can we help the patients? And so at Heart Valve Voice, one of the things that is very important is we have a heart valve disease policy task force. And there are about 30 nonprofit organizations that are members of this task force. And we hold a monthly meeting. And there's usually a guest speaker talking about something that's going on Capitol Hill, that we are all going to sign on letters, to show our support for the passage of a bill. So one of the key things that Heart Valve Voice likes to do is to get involved in policy and support policy that right now, early detection. There is no early detection for heart disease. We all have mammograms and colonoscopies and other types of baseline tests that we get. Yeah. And there's nothing that is standard a
For
standard
women,
heart for
or prior
women.
to, right, or prior to 65 or maybe 50 if there's family history, right? Men get it.
Right,
Right.
right.
What
So
happened to the rest of us? Yeah.
what happened to the rest of, we don't go off to pasture just because we hit 50.
Mm-hmm.
I mean, I think a lot of women I know that hit 50, we're hitting our stride. We're
Mm-hmm.
changing course and direction, and we are taking on a bigger piece of the puzzle because our children are raised, and this energy we have of what we did through the PTA years and all of that with our kids, we have shifted it into the health world, and you see it. You see all these
Mm-hmm.
women out there speaking. So getting on to Capitol Hill, and I'm going to go back to sharing stories. Sharing stories saves lives. And so we're on Capitol Hill. We meet with legislators from all over the country, and we talk about the people that they're representing. These are the
Right.
problems they're having. They can't get early detection. They can't get treatment approved. They can't get drugs approved.
Mm-hmm.
And so we are passionate about finding ways to help everybody, and also to help get equitable access to healthcare, treatments, diagnosis, all of that. So, so that's kind of the big part of Heart Valve Voice, is the policy side, and how can we help improve the patient's journey. I will
Mm-hmm.
guess I'll say it that way.
Mm-hmm.
The other side of Heart Valve Voice, which is a huge passion of mine because I love people, is getting out there and talking to people and providing support, educating, bringing awareness, attending health fairs, attending
Mm-hmm.
conferences, and just spreading the word. We have a great campaign called #AskForEcho.
Mm-hmm.
And that campaign is trying to get early detection, right?
Yeah.
Because so we've tagged on to that now. Everybody should be getting a stethoscope check,
Mm-hmm.
because it takes a second and a half to do it, or maybe it's a minute, right? By the time they do it. And that's how early murmurs are heard. And not
Mm-hmm.
all murmurs turn into valve disease. But
Right.
if you have a murmur, you should get it checked out. And that's
Right.
wrapping into advocacy.
Well, and the other
Advocate.
interesting thing about what you're saying, sorry, I got something just blew my eye, is
Right.
stethoscope checks, I believe, are almost more important than the echo. And here's the main reason why. Because in my own personal case, the physician's been hearing for a while. She's like, God, your valve sounds so bad. But this echo
Oh,
keeps saying it's mild to moderate. I don't understand. We're going to do another one in 3 months. I think that it can't be have you go to the hospital. That machine could be better. I go to the hospital. That machine comes back mild to moderate. She goes, Karen, your symptoms, what I hear, old school medicine before echoes were invented. She goes, I hear it. Well, then I had an MRI, a congenital MRI, and it finally came back moderate to severe. And even
wow.
still, they think it's just severe. So the echoes are really great at seeing things. The MRI, the congenital MRI it was like my first 3D imagery of blood
Of your
going
heart.
backflow, right? Because I have regurgitation. The ultimate's going to be the TEE, that
Right.
transesophageal echo, because it's going to be so close and he's going to be able to really see everything. But, you know, I don't think you should do an echo without a stethoscope, and you should definitely do a stethoscope is what would probably preempt to have an echo to begin with. So I think those
Yes.
stethoscope checks, and they happen at your physicals. This is why people need to have physicals. They just need to have a primary care to have a physical, if nothing else. Let them listen to you.
Right, right. But see,
Yeah,
that's what we were talking about earlier. Let's get the mobile clinics out into the
right.
community with a doctor with a stethoscope.
Yep, just listen. Just
Just
listen.
listen.
Hmm.
And it's just so important to not be dismissed. I do know, so this is part of my misdiagnosis story. In 1998, remember, I didn't discover any of my issues until 2007.
Hmm.
So in 1998, I'm pregnant with my first child, and my OB, who every time you go in, he would listen to your heart, because
Hmm.
then he's going to listen to the baby, etc. Right?
Hmm.
So if he hears a murmur, he sends me off for a cardiac workup, an echo, stress test, EKG, all of those things that you're supposed to do. And it comes back as mitral valve prolapse.
Right.
I don't have mitral valve prolapse. I've never had mitral valve prolapse. I still don't have mitral valve prolapse. That workup missed the bicuspid valve, missed the
Yeah.
aneurysm. And so the point in that is once you have a murmur, make sure you get it checked out.
Mm-hmm.
And I I have it's hard. It's hard because I didn't know that I had a bicuspid valve and an aneurysm at the time I was being told I had mitral valve prolapse. So I didn't really have any reason to say, I don't believe that, right? I had
Mm-hmm.
no
Right.
symptoms. So I'm out there telling people to advocate. Well, I couldn't really advocate another step because I just assumed that's what I had.
Mm-hmm.
Professionals have told me this is what I've had. And the good news is, though, the good news in a weird way is I developed a macular hemorrhage in my eye.
Mm.
I had to have a C-section because you don't want to have natural birth with an aneurysm that you don't know about.
Right. Of course. Of course. Yeah.
So I feel like my body was taking care of me. It's like,
Mm-hmm.
okay, so we've missed it right now. So I'm gonna give you this macular hemorrhage. So then I had two C-sections, still don't know that I have an aneurysm. So I
Mm-hmm.
do. I'm so blessed that I was able to give birth and have my two
Mm-hmm.
children. And so it's hard. It's hard to tell people how to keep advocating when you just accept what you have, right?
Right.
But a lot of people with murmurs are told, oh, it's that not, but it's not a big deal. No
Mm-hmm.
need to further explore it. I'm here to tell you, please explore it
Mm-hmm.
and then confirm it's no big deal,
Right.
right?
Exactly. We're not talking about having to have a CT. We're not asking
No,
people to become radiated in any way. It's a simple
no.
echo to will at least confirm where a murmur is coming from. I do think that a lot of people go right to mitral valve. I think because it's just so common, especially after a certain age, that a mitral valve starts to have some prolapse. And I do know that the valves can get better. So if you have regurgitation and it's moderate, it can go back down to mild with good blood pressure control because I've had mine fluctuate and I didn't know that was a thing. I thought it was like an aneurysm. They don't shrink. So your valves, once they go bad, they don't get
Interesting.
better, but they can actually get a little bit better. It's not stagnant. It's ever changing. It's ever
That's
changing.
interesting. I
It
like
is.
that. Good
Yes.
to know. I
But
know, Matt.
it's
Yeah,
important to know. It's important to know where it actually is coming from. I mean, I know they can hear it in your
right.
heart, but yeah, I agree. You need to have a picture just to verify and just know what you're actually dealing with. For sure.
Right.
For sure.
How about, can we point out about the congenital heart defect side,
Mhm.
about valve disease and
Mhm.
how it can be inherited? It's familial.
Yes.
So what I have is the bicuspid aortic valve, and it does run in
Yes, it
families.
does.
And since I am adopted, I didn't know my history, so we didn't
Mhm.
really know where it came from. I do know my birth mother's family and my birth father's family. I've since found them since all of this has happened. And it's been discovered in my father's family.
Okay.
And so it has been confirmed that it runs on his side.
Mhm.
And he's passed on. I have not met him, but his mother died at age 50, and they just called it in 1950 a heart attack.
Mhm.
So you
Right.
wonder, and
Right.
then you start looking at all the cousins and all of that actually have valve disease.
Mhm.
And so I think that I'm in touch with a lot of my cousins and some of my half siblings. And I just feel like I'm so grateful that they were open to hear my story
Mhm. Yeah.
because nobody in the family knew that there was this bicuspid valve running through the family line.
Mhm.
And so I'm so grateful that they were open to hear the story because now they have the awareness, right, for
Right.
their children and their
Right.
children's children. So, but congenital heart defects, both my kids have been tested, they don't have it.
Mhm.
Um, and so that was news for us, to just rule
Right.
that out, but they've got to be careful for their children.
Right. And just because you have an issue with your aortic valve doesn't mean that you have a aortic disease. It could limit itself just to the valve. And once you have an
Mhm.
aneurysm, your aorta is compromised. because honestly, you could develop an aneurysm in another location. It's not as though once you cut that out, you're one and done and you're fine. It needs to still be monitored, but anything that is contained in the heart structure, even if it's the
Mhm.
aortic valve, does not
Right.
necessarily then cause issue in the vessel itself that then extends out of that valve, which is also important to know. So if you have mitral valve, it doesn't mean you're going to have an aorta problem. Doesn't that,
Right.
right? So people think
Right.
that's all structure in the heart itself. It just so happens the aortic is the one that leads to the aorta, but it's still part of the heart. It's part of the heart. People just need to understand structural, even though we're not doctors. It's just
We're
structure.
not
It's anatomy.
doctors,
It's anatomy.
but you're so smart with this. I mean, I learned so much from you. And because I will tell you, after going through open heart surgery, so for 15 years, I lived as the girl who had heart disease. I've never called it heart disease, number one. It's like I've always called it heart condition. I have a
Mm-hmm.
congenital heart defect. I have an aneurysm, but I've never
Mm-hmm.
really embraced the word disease, right?
Okay.
I was raised by a mother who didn't allow illness in her body. She's now 99 and a half. So
Wow.
her mental strength was very strong. So I never really wanted to call it disease for me. I do now because I understand the whole bigger picture. But I will tell you, after living 15 years as the girl in the neighborhood who had the heart condition, who had an aneurysm, all my friends knew in tennis, don't push on my chest if I drop.
Mm-hmm.
You're gonna,
Mm-hmm.
all those things. I wake up after surgery, and about 2 weeks later, I go through an identity crisis. I mean,
Mm-hmm.
and I can still feel, it was so weird. I woke up and I thought, who am I now? Do I still have heart disease?
Yeah.
Everything's been fixed. I have a new valve. I have a new ascending aorta part.
Right. Right.
I mean, who am I?
Yeah. Yeah. You
It was
still
a
do.
weird feeling, and that's what I did. I called the doctor. I sent him a message in the portal, and I said, I just have to ask you,
Mm-hmm.
who am I? Do I still have disease? And he said, you
Mm-hmm.
do. And I said,
Right.
but how do I still have it when I am fixed? And he said, well, we still have to monitor you because, like what you were saying, the aneurysm could appear somewhere else.
Right, exactly. It's like people who have type 2 diabetes are automatically deemed as having heart disease. They go hand in hand. But if you get your A1C under control, don't you still have heart disease? Well, you do because it's being controlled, whether it's medically or it's through diet, whatever the case may be, but you still have type 2 diabetes. You just might not be active with it's like you can have Crohn's disease, but not be in a flare, not have a problem, but you still have it because it's genetically you still have it. So it can't change genes with medicine. You can suppress genes and symptoms that come from the genes, but you're not getting rid of the genes unless you look 10, 15 years in the future and maybe they can splice it out. I don't know how they do that, but it's gonna happen one day. That's like Star Trek stuff, right? Exactly. Or
It
Jetsons,
is.
whichever. I want to ask
It
you a question.
is.
2025 has a very interesting theme for you guys and for Global Heart Hub. Let's talk about
Yep.
this women in heart valve disease.
Yes. Excuse me. So, Global Heart Hub, this year they're focusing on women and heart disease, women
Yeah.
and heart valve disease,
Hmm.
actually. So, on September 1st, they just released the new report on women and heart disease. I don't know if you've had a
Hmm.
chance to read through
I
it.
did. I did.
So that was created. The great thing about Global Heart Hub, for those that don't know, Global Heart Hub is based in Ireland,
Hmm.
and nonprofit organizations become members, affiliate members.
Yeah.
And Global Heart Hub brings all of us members together to talk about current events. And so this year they've chosen women and heart disease. So they hold different council meetings. And from those council meetings, reports are created, action items are created, and then it's disseminated around the world by
Hmm.
all of the members. So that kind of gives you the umbrella structure. So I was actually in Milan for the Heart Valve Disease Council meeting, and
With
I was
Jenny, our very
with
own Jenny was
Jenny,
there.
with Jenny Schaefer. Love her. Oh my God. So we had a great table. I don't know. I'm sure she's spread the word about what we did, but we all had to create. We had to go in our group. So we were
Hmm.
obviously the North American group because we also had Ellen Ross from Canada, from
Hmm.
Heart Valve Voice Canada. And we had to come up with a real world problem, and they walked us through all these different steps looking at the problem and how to resolve it or how to implement change from every direction of every stakeholder. I thought that was so eye-opening because it really brings awareness. And since we are out here trying to work together and collaborate together, it gave us the awareness piece to think about every direction at the problem as opposed to just our own view. So fast forward, one of the things that was heavily talked about was this new report coming out on September 1st from Global Heart Hub on women's heart disease. And the 6 action items are spot on. And it just seems as though it, excuse me, it seems as though a lot of organizations this year have focused on heart disease, women and heart disease. And I'm also a women heart champion. And so our whole focus at Women Heart is women, right? And heart disease and how we can help. So between the two, I get, I'm just looking for my Global Heart Hub notes on.
That's okay.
Because I think it's super important to let everyone know the takeaways. So,
well, and the first thing that would be of interest, I think, is why do we even separate the sexes out? Why do we differentiate and talk about women and their own heart health or any kind of health issues? Why are we breaking it away from just general population?
That's a great question. How many men in the ER have been asked if they have anxiety? And they've been given Ativan and sent home. So can we just start there?
Right.
We'll just start with the presentation of a woman presenting at the ER at the same time a man does with the same chest pain, right? One goes straight back to the cath lab. The other one is put back in the waiting room and told that she'll be with them. So
I know so many people who literally, it was the 11th hour before they were given a CT scan. They were literally being told, let's just put you inpatient, because they just knew something didn't feel right and they were blaming it on anxiety, throwing all the anti-anxiety meds at them, only to find out when they did the CT scan that the person's walking around with 5.5 centimeter bicuspid valve and needed to have emergency surgery because, we're full of so much anxiety.
Right. Well, during endocarditis, I was told that I was constipated.
Right.
So I was given Miralax, Ativan for anxiety, and discharged. And I had an infection. I was turning septic. So male ER doctor. So anyway, so yes, the differences of men and women is one of the key aspects of this report. And it's important to educate the world on the differences of how we present. Some of our symptoms sure are the same, shortness of breath, fatigue, those types of things. But you can't just discount our symptoms because we're in menopause or because we've crossed menopause or because we have 5 kids at home and we're tired. So the difference, the men just walking in, it's a different level of respect for their presentation. And so women have to double down on owning their truth, owning their symptoms. So part of the report, so historically, my understanding in research is that women are and have been completely underrepresented, right? So if you go all the way back to research, so medicines that I'm on, that you're on, probably were based on men.
The results were based on it being tested on men. Absolutely.
Right.
Absolutely.
So our dosage is always kind of adjusted. Well, you're a woman, so we'll adjust it a little bit. I think. I don't know. I'm not a doctor.
No, that's true. And that's based on weight. That's more based on weight, I think, than just gender. But but when they're giving medications, you're right. This has been discussed. I can't remember what physician I had on, but when we're taking a medication, it's based on the result of what it did to a man's body. And we are not the same body. We do not have the same hormonal makeup. They do not impact us the same way it could potentially impact a male. And to think that this is only now really coming to light, I don't understand. It just seems so basic and elementary that that of course there's going to be of course there's going to be differences. They're just it just will
so be. It is. It's I have heard, though, that one of the reasons why women weren't invited into the studies is because they didn't want to deal with the hormone changes. So I don't know if that's true or not, but it kind of follows the line of And I think it's because women's voices are becoming louder and louder in terms of,
Mm-hmm.
hey, we're just as equal. And the thing I keep hearing at conferences is there's more women in the world than men.
Mm-hmm.
So why are we underrepresented,
Right.
right?
Why aren't we being studied?
And
Yeah.
so so there's 6 actions, and it all kind of, because women are different, it's getting more women into research, heart valve
Mm-hmm.
disease research. How do we get more women in? Because then the conversation opens up to the hurdles and the barriers, right? Because
Yeah.
if you want women in research, then sometimes they're the main caretaker at home of both
Mm-hmm.
aging parents and their own children. So now you need a babysitter. So there's a financial problem in terms of how do you pay for all of these sitters to watch your family while you're off participating in research.
Exactly.
Some people don't have access to good
Mm-hmm.
computers to participate. They have to drive a distance. I mean, there's all these
Mm-hmm.
hurdles. There's financial, it's the economic, the distance, the just basic in life. How I've lost my train of thought, where just getting women to the research study, there's a lot
Mm-hmm.
of hurdles, but we have to
Right.
overcome that. And that's what we as patient organizations keep working on, right?
Mm-hmm.
We're working on what's the answer to that then? What
Mm-hmm.
programs can we implement to help women overcome those hurdles, right?
Right. Yep.
And so another, excuse me, one of the things we talked about is education, right? We need to educate women and their families on the importance of being in research, the importance of knowing your symptoms, the importance of advocating.
Mm-hmm.
And so Global Heart wants to support creating new resource materials, educational materials, to bring the awareness to the patients, the families, and the clinicians. How
Mm-hmm.
are we different? How are we different as women from men? And we
Mm-hmm.
need to educate doctors that we are different, and please give us more respect, more leeway, more consideration when we
Yeah.
present to you.
Right.
And I would love to see new modules in medical school,
Mm-hmm.
just start from the basic, because
Mm-hmm.
I do see a shift, though. I will tell you, at conferences and in conversations across the globe, I do see a shift in the younger generation, both
Mm-hmm.
patients and clinicians,
Absolutely.
nurses, doctors, staff, in terms of their awareness of the differences of women and
Mm-hmm.
heart disease and just women in general. I see them embracing the differences, embracing the knowledge, embracing the fact that they do need to listen to us and not just dismiss us.
Right.
So super excited for that shift, because I
Yeah.
think that is where we are headed, and it's going to benefit everybody behind us. All this work we're doing right now, Karen and Jenny, and all the people that we know in this world, is going to benefit people behind us. That's why we're doing
Mm-hmm.
what we're doing, right?
Mm-hmm.
So let's keep going. And okay, so that kind of leads into the third one. Train healthcare professionals in gender-specific presentation and
Yeah.
progression of
Yeah.
heart valve disease. So
Yeah.
same idea. Implement targeted screening campaigns for high-risk female populations. So high risk, so it kind of then ties into the next one, which is expanding access to diagnostic technologies, especially for underserved groups.
Mm-hmm. Mm-hmm.
So those two kind of, to me, can go hand in hand, and they can
Yeah.
also be taken separately.
Right.
There are so many underserved populations, female and male. I
Mm-hmm.
mean, it's there. And then you add being a woman, and then you add the risks of, what if you had risks, the pregnancy
I was just going to
complications,
say that. I mean, and you think about how much larger our hearts grow when we're pregnant. What's it, like 3 times the size? So
something
our
like that.
hearts are already expanding. And so we're already having changes, the hormonal changes, the physical changes that come with a pregnancy if you are pregnant or if you get pregnant. So then if you're developing any complications or issues afterwards, to be told that your postpartum could kill you. And I had preeclampsia, and I still sit here to this day, which of course it was many years later, 16 years later, that everything happened to me. And I think if somebody had a blood pressure in the 200s over the high 100s, why wasn't an echo done, like, at all before? Now I had a C-section, but because of that. But why wouldn't a physician think, let's just do a quick echo before you get to the ninth month? Because there's no way you can tell me that changes can't occur over 9 months. If the heart's growing, your vessels are growing, and if you've got such high blood pressure, of course there's a chance that you could have an aneurysm now. So you would think that common sense would say,
Wow.
let's screen a woman. That this is non-invasive, an echo. It's not going to hurt a baby. And let's screen them and make sure that they are safe to push, to just push all that pressure and
Wow.
pushing, right? I can't even cough after you can't even, they don't want you to strain at all with an aneurysm, anybody, let alone
Right.
let's let a woman push a 7-pound human out of their body when they might
Right.
potentially have a an aneurysm. So yeah, it's a soapbox I could
Wow.
stand on for a long time, but there's just you're right. And I think that targeted screening needs to happen. I don't even understand why at my age, 56, when I went on Medicare at, I don't know, 46, 47, I was being told that I couldn't have a pap smear, but every 2 years, because that was the rules of Medicare. Of course, you just tell your doctor, I, I think there's an issue. Let's do it. And they're like, okay, we'll
Yes.
get you in. There's ways around the
Yes.
system. But it's just amazing to me that my mom at 81, it's like, you don't even need to come back. Some doctors are like, it's been real, have a good life. They don't even want to see him
Right.
again because what would it matter? And I think it matters. And
It
I
does
think that,
matter.
if like Dr. Martin was saying last night, that yes, it's typically paid for a male 65 and older who's a smoker, overweight, gets in and gets to have an ultrasound of their abdominal area for free. Boom, it's done. And if you're 50 with with a family history, or you might have some other issues, yes, you get to do it at age 50 and above. Where's the screening criteria that's saying it's okay for a woman? Mm,
Right.
right,
But see, that's what we're doing in policy, right?
right. That's
Because
what we need.
insurance companies follow CMS.
Right.
And so that's
Yeah,
why, we sign these letters over to CMS to try to get treatments paid for, covered under the Medicare system, because then we're hopeful that the insurance system will then cover it as well. But there
exactly.
isn't. I mean, I haven't gone into the Medicare world yet. That's a couple more years for me.
Hmm.
And I hear great things.
It is. Yeah.
I hear great things
Hmm.
and about treatments and those types of
Uh-huh.
things. But so it'll be interesting to see when I shift over to that era. But how about, like, you and I have talked quite a bit about how can we get into the underserved communities in your area, like,
Right.
Baltimore, Washington, D.C.,
Right. Right.
and so many of these
Even the rural areas, right?
the
They're
rural.
gonna. Everybody thinks when you say underserved, they think city.
Good point.
You know,
Excellent point. Yes, it's rural, right. How
let's
do
go
we
out to
help rural
Idaho.
healthcare?
How many people are going and getting scanned easily in Idaho without making a 2.5 hour, 3 hour trip to go get their annual scan? It's a
Right.
process, it's a thing. And to have somebody maybe be able to drive that to them would really be very helpful. And there's a lot of people I also think culturally that don't want to know because they don't trust the medical system because history has proven that they shouldn't trust the medical system. And then there's the people that they go and get screened, they find out they have this and they're like, what am I supposed to do with this information? I have Medicaid or I don't even have insurance. What do I do now? Now you just told me that I have something that I could die from. What do I do? So there's a lot of holes in this. Even
Yes.
if you can provide the access, how do you uh, have a society trust you that you are telling them the truth, that you're not just trying to operate and make money, that you now can provide good, solid follow-up care, that the cost is minimal to none. There's a lot that goes hand in hand once you're able to give the access. It's hard.
And that's the soapbox I'm on
You
in
take that
terms.
box. You take that box, and once you fit, then you can send them to me, and I'll put them in a support group. It's a big soapbox. It's hard. It's the stuff that keeps you up at night.
It's it does, because
Yeah,
here we're out here advocating for people to go get tested, get screened, eat
right.
healthy, but
Hmm.
yet healthy isn't an option sometimes when you live an hour from town
Yeah,
and the $20 you have that needs to feed your family that night
Right.
You can get 4 meals at McDonald's, but you can't get
You
4
can't get
healthy
fresh
meals.
fruits and vegetables.
You
Mm-mm.
can't. So,
No.
and like these screenings, we want to do these screenings, right? And so the screenings that I have seen, in terms of been at an event and they've had screening, there's
Mhm.
always been a follow-up plan for anyone who needs a secondary look.
Right.
So
Right.
that is one of the biggest hurdles. So we need industry, we need
Mhm.
money to come
Mhm.
to us, to the nonprofit patient groups, to help fund these early screening programs or screening programs, but the money needs to come to then pay for the doctor follow-up for these people,
Mhm.
right?
Right.
So that's what we're talking about in the big world. We really want people to be healthy and be aware of their health, know their risks, right? And that's a
Mhm.
whole nother big, know your risks. Well, what does that really mean, Robyn?
Right.
Know
Yeah.
my risks? Okay, so I know my risks, now what? So it's starting the conversation. So I go back to the grassroots that I like, where at least we're having the conversation,
Yeah.
right? And maybe it's the women and men that are following behind us at Aortic Hope, at Heart Valve
Mhm.
Voice, at all of these other nonprofits. It's that they're going to solve the next set of problems, right?
Exactly.
I think we've just blown open this world, and having the
Mhm.
conversation
Mhm.
gets change.
What was the
And
6? We didn't get to the 6. I'm counting. One,
the
two, three,
6
four,
is
five.
okay, so 6 is amazing. I think
Okay.
this is, and this circles into the support group we had last night for My Valve, My Voice. Super interesting. Provide ongoing person-centered care and lifelong support for women with heart valve disease.
Mhm.
Okay. So how that came up in our support group last night was the mental health aspect.
Mhm. Right.
And that's a whole nother soapbox, right?
Yeah.
Because you've got the mental health of being diagnosed, the shock
Mhm.
of the diagnosis, then you've got the watch and wait or the emergency treatment, and then you've got the
Mhm.
discharge. And someone said last night so eloquently, it was perfect, that goes with this.
I just want everybody to know that Robyn is the most exceptional note taker you will ever meet. Her notes are not just like my scribble notes on a piece of paper, okay? Like her notes are columned, date, subtitle, I mean, and when she sends it to you, you're like, we talked about all of that. That's like incredible. Yeah, you're a very good note taker. All right, go ahead. Sorry, I interrupted.
Thank you. No, you gave me time to find it.
Okay, good.
So this to me circles right into the ongoing patient-centered care and lifelong support. Quote, it's the human side after going home, end quote.
That's
It
why
brings me
aortic
to
coat was
tears.
fit. That's why we were created. That's exactly what it was. When you come home and they
Tell
say to
me.
you, go live your life. And you're like, what? Can I, what if I sneeze? Remember when you were pregnant and you thought, oh my God, I have to sneeze if the baby's going to come
Yeah.
out? Okay. Everybody, every single woman thinks it, or I have to go to the bathroom and
Right.
it's just going to come right out. And it's so hard to believe that there's a literally like a human being and it's in you and it's not just going to
Right.
fall out. And we do this for 9 months until we're like, get out. Right. And so that's different. Then we want it out. It's the same thing when you've had heart surgery or you have an aneurysm or whatever. It's just your imagination plays in your mind. We're not doctors. We don't understand the mechanics. And when they simply say, okay, see you next year, you're good, go home and enjoy
Yeah.
life. You
Enjoy
just
life.
sit there, you're like, wow. Like with a dissection, you just wait, like a week ago, you told me I was about to die and pick a place to be life flighted to, as if that's not jarring in an ER. And now you're telling me, okay, you're fixed. See you in a year. Go live your life. I don't even know what that
Right.
means. What does that mean? So we've tried to figure out what that could mean for people. So
Oh my gosh.
important.
Well, I need to circle some of these people last night over to you, to some of your resources, because I will tell you, the lifelong support for women with heart valve disease,
Yeah.
as how it came up last night is, let's talk medication.
Mm-hmm.
Okay. After open heart surgery, a lot of people get off meds, right? They get
Mm-hmm.
off all their meds, and because they're doing much better. Some people have co-issues, so they have to continue to take medication.
Mm-hmm.
Some people, like in my case, I'm continuing on the same medication as before. I think a lot of it is preventative,
Yeah.
because I'm young and I want to live to 90 plus if
Right.
I'm healthy.
Right.
So we all have our different reasons why we are on medication and what we choose and what our doctors suggest, right? But what happened last night is we started to talk about the mental side of walking into the pharmacy every single month as a young person. So I started in my 40s and taking a bag of pills home. And you've got everybody behind you looking at you like,
This is so horrible. It's so bad.
right?
Oh my God. I've been through so many different types because I just want the ones that are pretty and look like Louis Vuitton cases because this drives me bananas. It's great, but it's great for like sitting in my bathroom where nobody else has to see it. But
Right.
just nothing's more depressing than every Sunday you have to do this. And it's funny, not to cut you off, but to cut you off.
No, it's
We
okay.
have a
No, this
women's
is,
only support group meeting. It meets the last
yes,
Monday of every month. And some of the themes that the women will talk about is, once you're recovered, there is this underlying expectation. Okay, you're going to start cooking dinner. When are you going to start cleaning up again? So-and-so needs to go. It's 9 o'clock. They need a poster board. Can you run out real quick at CVS because they're just telling us for their school project due tomorrow at 8 a.m.
so typical.
And they start looking at us like, come on, you can just do it. But we were
Let's
tired
go.
from all of that before. And
Right.
now we need to manage this. And we're very stoic. Women are very stoic human beings. We don't usually complain. We can have
Right.
colds, or we can have COVID and bust through anything, right? As soon as
Right.
it's the stereotypical, if a man gets a cold, they're like, oh, they have a cold, right? Okay. I don't know how much I
I
believe in
need
that.
drumsticks.
Yeah,
I
I
need
can't. I can non-functioning. Except my husband, he's really not like that at all. I am 1000% like that.
Excuse me.
But one of the things that they talk about is how do you manage your new 2.0 life from whichever it is, heart valve disease or aortic disease. How are you supposed to balance and manage your life with home life and or job life? It is
Right.
completely changed and turned everything upside down. And how do you find a space for that? And that literally in of itself could be a whole conversation. That we're going to have to follow up on. But before we go, before we continue, I want to check in and see who's here because we've been like,
Yes.
rub, 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 rub. I want to see if anybody has anything they would like to contribute to this conversation.
Hazel
Go ahead,
wanted to come
Josh.
in.
Hello, Hazel.
Hi,
So,
Hazel.
hello, please and thank you, and Molly, and LG, and Lisa. Please and thank you chimed in early during your story there, Robyn, and she said, even though you didn't have medical records from childhood, none, there's like 9 O's, none of your doctors caught this genetic problem until you were 44, 4 question marks. That's pretty shocking.
Yeah. Well, it is shocking. It absolutely is shocking. However, why would they have caught it? I was asymptomatic. I didn't know it. We didn't know that it ran in my family. The only thing, how they get caught now, I think earlier, which is great. I was an athlete my whole life. I was a long distance swimmer with a great club called Mission Viejo. I was a big collegiate sailboat racer on small boats, dinghies. If you know anything about it, you're hanging out over the side with your legs under a strap, hoping not to fall out. I've been a tennis player my whole life, so I have always been super athletic. And now athletes are being screened for heart issues, I think,
Yeah,
as part of their physical.
correct.
So the good news is it's changed. So
Hmm.
athletes, but why not everybody, right?
Hmm.
Because just because you're an athlete, yes, it's super important to know your heart risks when you are going to be swimming 20,000 meters a day, when you're going to be out hiking on a boat 10 hours a day. It's
Hmm.
super, and playing football and all of those things. But yes, to me, the biggest missed opportunity, because it wasn't part of our culture then to screen athletes, the biggest missed opportunity was 1998 when I was screened and it was missed.
Hmm.
And I believe it was missed by my local hospital, probably because bicuspid aortic valve sometimes can be very difficult to see in an echo, and there was no reason for me to have a CT or an MRI.
Yeah.
And if you are not used to looking for the bicuspid or seeing it when it appears, I think that it is very difficult. So it's very important to make sure you are at a congenital, if you can get to a congenital heart center, if you've been diagnosed with congenital heart disease, because they see it
Yes.
all day long.
Good question, please, and thank you. Thank you.
I like
Right,
please and thank
excellent.
you.
Yeah, we're big fans. LG, this person says pre-screening is so important. It seems with valve and aortic disease, it's not caught until an emergency happens. What if there's something that can be done to slow the growth or progress?
Right. So Think Aorta is the campaign that is trying to diagnose individuals before there is an emergency. And they initially started based on we wanted people who were having a dissection to be identified in the hospital and not be overlooked and sent home and underdiagnosed or misdiagnosed. And then when the US took it in, we started looking at it and we went back to the UK and we said, but what if we took it a step backwards in time? And we said, yes, properly diagnosing dissection, very important in the hospital. But given the fact that some hospitals in the US might see one a year, one, right? They're seeing
Wow.
one, they're freaked out, and then they're sending that to the hospital that gets 20 or 30, often. Um, what if we try to identify who might be at risk for aortic disease in general, including aortic valve disease? If we can find those people based upon family medical history and other symptoms, and we can diagnose them at risk, now we can follow them and hopefully slow down progression of growth by medication, hopefully reduce the chances of needing any intervention sooner than later because we've been monitoring them. And if there needs to be intervention, it can be planned, which is always better than emergency. So that's kind of the messaging that I know we've been trying to instill, and I know that you guys are doing that as well now. It's about
Yes.
early diagnosis. It's having those open conversations and discussing them.
I wrote it down. I loved it. Diagnose at the risk identification level, so that way you can watch and monitor.
Right.
Because LG, you're correct. A lot of severe aortic disease is discovered in the emergency room because a person has presented with another issue. And then all of a sudden that issue has become secondary to their open heart surgery or their TAVR to fix their diseased valve because they had been asymptomatic.
Right.
So you're going to start hearing a lot in the news about asymptomatic research. How do we get that? So that's why I wrote this down, Karen. This is perfect. This is something we are focusing on.
Your notes in those handy, trusty,
My notes.
dandy notes.
You're going to get some notes.
Thanks, LG.
That's great. Lisa has a question. Do you have an underlying condition? Have you been tested for AHTV? Any history of stroke? She has 3 questions.
Interesting for me. I have not had any genetic testing done. It's something I've been considering now that there's seems to be a lot more genetic testing out there for these heart valve issues. Do I have a connective tissue issue, with the aneurysm? Who knows? Do I have a history of stroke? No. Does my mother or father's family have history of stroke? No. Or heart disease? So it's just this one little issue. And no Marfan's, no, is it Ehlers-Danlos?
Ehlers-Danlos or Loeys Dietz. And it's interesting. My father had cardiovascular disease, 45. He had his first of 2 heart attacks. And I immediately at 25 started seeing a cardiologist because I said, I'm never having that happen to me. And then I went on to have preeclampsia, took blood pressure pills, not as often as I made sure to take the birth control pills. Just didn't think that 138 over or 140 over 90 was a big deal. I'm sure it'll go down tomorrow. I just was so dismissive because nobody educated me. I was young-minded. I wasn't compliant. And then they found that I had an enlarged aorta when I went for a bowel resection surgery, and nobody ever said anything. So 3 years later, I end up having a dissection. Yeah, it went into the notes, into the primary, into the cardiologist I had. Everybody just kept their mouth shut. It was like, I don't know, 4.2 or something. So yeah, definitely an aneurysm, and had the dissection, ended up having 2 TIAs. My father had an abdominal aneurysm. I evidently had a thoracic. I also detached my retinas way before my son was ever in the picture. So I detached retinas. My father's mother detached her retinas. So did my sister. So there's all these things, but nobody thinks because you appear healthy, nobody puts the pieces together. I have had genetic testing done twice now. There's 38 aortopathies in that type of aorta panel. And then this last time, because my father passed suddenly, they added a cardiomyopathy, and lo and behold, I have a cardiomyopathy gene. So it's
No.
probably the explanation as to what happened to my dad. So that's a whole other fun thing to do. But I do not have anything directly related to why I had a dissection yet. I do have a VUS, or a variant of unknown significance, that now officially got a number behind it. But who knows? In 5 more years, when they have more, maybe they'll figure it out, or they'll determine that that variant that was of unknown significance now might be significant because more people have it. So it doesn't really matter. I have not had my son tested, and I won't. He's just treated as if he has something. So he is scanned, he is monitored every 3-5 years. And if there's a change, we'll be on top of it like white on rice. Boom. Be ready to
That's
intervene.
great.
Yeah.
Wow, good
Yeah.
question.
Big questions, Lisa.
Right? And LG has a statement.
Sure.
Can't find solutions or conduct studies if you don't have mechanisms to find the population.
That's true. And sometimes it's hard to find the population. I was talking to Dr. Udelman, and it was interesting during COVID. And I am not quoting his stats because I will butcher them, but I'm going to give you the general premise. And during COVID, they stopped. So what I didn't know is, if you go into the hospital because you think you have pneumonia and they do a CT scan, you're being followed for the pneumonia or what you have. But at some point during the day or the week, that film ends up in a thoracic surgeon's hands just to take a look at, because it's a protocol thing. They just do a quick glance and move on. Well, there were
Interesting.
no scans coming to the surgeons during COVID because there was too many scans coming in every hour. I mean, Brooklyn, hotspot, there was just way too many people with COVID and issues with their lungs. You just didn't have the time to look at everything. So after about 3 months passed, he started asking, can I see these scans? And what they were finding was a double-digit percentage of the scans that they had from many, we're talking, hundreds of people during COVID, all had aneurysms of over 4.5. And
No.
of those people, it was at least a single digit needed to have surgery as soon as they recovered. So if that's from one hospital, he started making calls, and they started finding the same thing. So, if this is just in one hospital system, what do? I go to Disney and I look at everybody staring at the castle at the end of the day, waiting for fireworks. And instead of everybody like scoping out, this is my spot, get me a candy apple, I'm looking like, oh my God, about all of you probably have an aneurysm and you guys need surgery. That's what I do in my head, because you don't feel it, you don't know. So what is the mechanism to get to people? And I think it's just through continuous awareness. And like you said, telling the stories. So sharing our stories, SOS, saves lives, right?
Right,
SOS, sharing our
exactly.
stories. And that is the key. And yes, sharing stories is validating. And yes, it makes people feel good when they get a chance to get it off their chest. But more importantly, when we can get it out into the general public. Um, this isn't, yes, skin cancer is very important. Every health issue is important in its own right,
Yes.
because you just put some lotion on, right? Go get a skin check once a year. These are very easy things to do for yourself.
Right.
But if you know you have a family history, it's also very easy to tell a doctor, can I get a baseline? Can we just check me out? If you think I'm good, I'll come
Yes.
back in 5 years. We're not
Right.
talking hard stuff. And we're talking that if there's a concern or a known family history or suspected, your insurance probably will pay for it. So that's your reason. Won't pay for it yearly, but it might pay for it every couple years unless something's diagnosed. It's communication, just communication, I
So,
think.
and you bring up the good point of sharing the stories is absolutely imperative.
Mm-hmm.
But now I'm in the phase of, okay, sharing the stories is fantastic. And I want to keep hearing the stories from everybody because it's excellent information on the big
Yeah,
picture of what's out there. However, we now have to take those stories and create action, right?
right.
So we're in the action phase now, and that's where I'm super excited that we're headed. It's like we're taking action. We're not just listening to the stories anymore.
Mm-hmm.
Super important, but we now have to make something happen. What's
Right.
the takeaway? Know your
Yeah.
family history.
Exactly. Think aorta, think family. But at the end of the day, it could be Think cancer, think family, think diabetes, think family, think stroke, think family, think heart disease, think valve disease, think blah, think family. That's the key with everything, because we know it's all things are going to end up leading back to some type of genetic predisposition. Not everybody that sunbathes is ever going to get skin cancer. This is never going to happen. But the fair skinned people tend to have an issue sometimes with getting some skin. Look,
Blue
my sister's
eyes.
had it. My sister's had it multiple times. I mean, I was a kid who laid out with body oil, like baby oil or whatever. I don't know what
Band de
Crisco, who knows?
Soleil.
Right, Bane de Soleil. God, I can picture it and smell it orange, and it was
Ugh,
like amazing, right?
orange grease.
But some people just are they have a predisposition for certain
Yeah.
things. But you really can't get like your entire genetic line, your entire DNA tested for every single known thing. But you can pick
Yeah.
certain things if it's important to you. So I did have cancer. So I have no BRCA genes. I kind of knew that already, but I just wanted to hear it and feel it and know that I'm fine. I know that I'm not at risk for Alzheimer's or certain dementia. My grandfather had Pick's disease, so that missed me too. Instead, I just had a cardiomyopathy gene, which we're not going to talk about because it's super duper scary, but it's okay. I'd rather know so that then doctors, if I have a change, can be on that right away, giving me medications or a pacemaker, whatever they need to do, so I don't have an outcome like my dad, who didn't know he had it. So in a way, I'm happy. I'm happy that I know.
I'm happy that
Yeah.
you know, and
Yeah.
your son's happy. You know, at the end of
Well,
the
not so
day,
much. He's not so
well,
happy. So because you have to think when they're younger, they get all like he has something too. He has a blood clotting disorder, FLNC. So he figured that out from his dad and his uncles and his grandmother on the other side. So he can produce clots, too many clots. So he's got to get up and
wow.
move during the day and whatever. If he stubs his toe, I'm getting a call at 2 a.m. I have to stub my toe. Am I going to get a blood clot? Is it going to go up my leg? I'm like, no, you're going to be fine. So there's also a risk for some people that when they know these things, it does now play in their mind a little
Yes.
bit. So it's not a one size fit all with education. I think knowledge is power, but I think it also can be like when I walk into a doctor's office to discuss my plan of care, I know way too much. So we are talking high level speak, high level words, and
Mhm.
I'm very well aware of what I'm facing, and it brings me comfort, but to somebody else, it might freak them out. So
I
different
agree.
strokes, right? Yeah.
Right.
All right, Josh, what else
Wow.
do we got?
So Molly's got some things to share.
Okay.
Hi,
First
Molly.
question. So why the influx of aneurysms? Was it because there was an increase of patients and scans?
Oh, from Udelman, when he finally can catch up and review all of those scans that came in during the period of time over COVID. It was just, and it had nothing to do with COVID. So you start thinking like sometimes you'll get them, maybe you might not get a scan, it all depends on the week and how busy. But in COVID, he wasn't getting any. So he was like, let me take a look at these. It was like 1,200 scans he reviewed over a 3 or 6 month time period. And he was just baffled from age 18 on up. There was no rhyme or reason, non-COVID. These things existed before COVID. You're not going to have COVID and all of a sudden develop a 5 centimeter aneurysm. Like it doesn't happen like that. That's not how the body works. So they were not related to COVID in and of itself because you have varying degrees of the disease. Um, but it was just shocking to see that when you had a chance to sit down with a large amount of data and look at it all at once, it's like, wait a minute, this is 1,200 films and look at what these results are yielding. Like maybe we never even realized that before because those 12 were spread out. And that's what I think probably happened. And I'm curious to know if he's like what he's finding since then. Like if you go to the next batch in year 2022, what did you see? Um,
Hmm.
yeah, that's we had never really talked about it because he's getting his paper written. So I don't know what the outcome is,
I can't wait
but
for that paper because,
yeah.
I think Molly wants to, if I'm reading into it, why are there so many aneurysms? I mean, we know now how he discovered them,
Yeah.
but why the increase? Because I mean,
Or is it an increase? Or has it always
or
been
is
there
it
and we
an
never
increase?
knew?
That's right.
Yeah, because
Be,
this was a like hostage amount of people who went into the
right,
hospital. And these people,
right.
other than that, would have just been living their life, like you said, until there's a problem. They've just been living,
So
nobody would have known.
nobody would have known. I know.
Hmm. Yeah,
I think the statistic on bicuspid valve is 1 in every 4 or 5 people are born with one.
that's crazy to
Something.
me. That to me seems
So
high.
it does seem high. Don't quote, is it
Yeah.
1 in every 100? I'm
Well,
going to look it
4
up.
or 100 is a really big difference, but even let's say it's 1 in 100, it still seems high. I would think the uno cusp or unicusp or quad cusp is probably even rarer. I think bi is the most common next to regular tricusps.
See really quick. Okay, it's 1 to 2% of the general population.
Well, that would require me to know how many general population people there are, and that is just a stat that's
Exactly.
not in my head.
Yeah.
Don't pay attention to that.
Nope.
That's
Nope.
out.
Nope.
No, too much math. You're going to start adding letters in the math, and then my head's going to blow.
No more math. But I do know that it is the most common congenital heart defect.
Yes, it is actually. Yeah. Mm-hmm.
So
Yeah,
it's
very common.
And
yeah, I can't wait for the paper.
Molly's second question here is, do all hospitals have the protocol of pushing scans / x-rays, etc., to other disciplines?
Do all hospitals have a protocol of pushing those other scans, x-rays, et cetera, to other disciplines? Well, I don't know if what you're asking is like, for instance, if you go in with an abdominal issue, they're immediately going to want to do a CT scan of your abdomen. Like that's just that's a protocol. Because they don't know if you have something lodged, if you've perforated, if you like that. I know because I've been in the GI world. Like if I go in with pain, I'm probably drinking something nasty if I can get it down, and I'm going to be taken back to a CT scan, and it's just going to be horrible before they're willing to give me anything because they just don't know. And that also lights up your gallbladder, your everything. Like if you have an appendix, like that's all coming about. Or they're going to do an ultrasound because if they're pretty keen on they think it's your appendix or your gallbladder, then they're going to go right in and just use the ultrasound and confirm right away. They may also still do a CT without having you waste the time of drinking because it's just probably going to come back up. But then if you think about it, if you have something orthopedic, yeah, they're going to put you right into an x-ray. MRI is just never used. It's really never used as a protocol in hospitals. I know this because it takes too long and you can't bump somebody from a 40-minute procedure. You can bump somebody out of a CT because that's 5 minutes. You can bump somebody out of the next x-ray because it's 2 minutes, but you can't bump somebody when they've been scheduled for the MRI, which is why you very rarely, if ever, have somebody say, all right, we're gonna take a look at you. We're gonna put you in the MRI. That's 45 minutes before they get in touch with you to tell you what's wrong. That just doesn't
interesting.
happen. Yeah.
Interesting.
I don't know. I have random bits of information in my head.
You are so smart.
I listen. I pay attention to the doctors because I love Grey's Anatomy, and so in some weird way, I like to feel like we're a kinship.
Yes.
I don't know. Good question though, Molly. If I got it right.
Yeah, and that's the end of chat.
I think that is the end of chat, and we're at 4:07. Look how easy that was. That was fast and super easy
fast.
and super fun.
Super fast.
So fun.
I mean, so fun.
You and I could talk for hours. We really could talk for hours. You are so well informed and so well versed, and I learn something from you every single time. I'm so honored to know you and be following in your footsteps of just advocating and learning, and you inspire me to keep going. Really,
I feel
truly.
the same way about you too. Don't hang up when we say goodbye to everybody here. I have some things to chat with you about, but to everybody else, thank you, everyone. Please and thank you, LG and Molly and Lisa, and I always forgot one, Josh. I don't remember the other person's name, but
thank you.
Yeah, thank you. Thank you so much. Do me a favor, click like, click subscribe, and click share because somebody will find this very informative if you share this on your social media. And I will see you guys soon. Take care. Have a great rest of your day.
She has a clarification here.
Yes.
She squeezed a clarification question in here. Okay. What I mean is your CT for appendix gets seen by that specialist, but do they always push it to say a cardiothoracic?
Anything that's going to involve the chest, my understanding is at some point a cardiothoracic will touch it and should take a look at it. That's my understanding. Do I think it happens? I'm going to guess no, but that's a great question. I can ask Ben Udelman, and I will ask him, or I'll ask one of the physicians that we have. Yeah, that is a good question.
I think we're clear. Go ahead.
All right, everybody, take care. Have a wonderful rest of your day.
Bye. Thank you so much. This was great. Thank you. Bye.